So what antibiotics you're gonna use depends on, are you suspecting a resistant organism or are you not suspecting a resistant organism? That means a community organism. Now, mind you, some communities do have resistant organisms out there. For example, strep might not be responsive to azithromycin up to 20% in some communities. So if you suspect an atypical pneumonia from streptococcus, then you still might have to use something else other than azithro. This is a very local decision, and it usually depends on something called the antibiogram, and most infectious disease specialists and hospitals keep track of what their bacteria are sensitive to in that area. So if your patient has a non-resistant organism, or you suspect by history, by the clinical findings and the imaging and the risk factors for the patient that they don't have a resistant organism, then you're going to treat them with one antibiotic for strep, which is the most common organism, in addition to antibiotics for atypicals. This is strep and H flu, and one antibiotics for atypicals. Or the same antibiotic can cover both strep and atypicals, for example, some of the fluoroquinolones. As far as suspecting that the person has a resistant organism, including MRSA, gram negatives, and extended beta-lactam resistant organisms, you will have to change your approach to cover MRSA with Vanco or linezolid, and you're going to have to cover the gram negatives with 2 antibiotics that can treat Pseudomonas. Because if Pseudomonas, which is notorious for developing resistance quickly, is resistant to one of the 2, then you're likely to be sensitive to the other, unless your patient has an history of MDRO. If the person has a history of MDROs, then you have to depend on the prior culture results to choose your antibiotics accordingly. So antibiotics that treat resistant gram negatives are usually either a carbapenem or carbapenem, like meropenem, or a combination called Zosyn. So you start the treatment, and then you need to figure out, is the patient responding to the treatment? So day 1, day 2, and definitely day 3, you want to measure a couple of things. The white cell count, if it's too high or if it's too low, it's a problem. If there are too many bands, if the PaO2 to FiO2 ratio is calculated, if this is increasing, which is better, or if it's decreasing, which is worse. And you want to look at a chest x-ray. This is on day 3, chest x-ray, to see if the infiltrates are progressing, or if they are stable, if they are lobar, or if they are diffuse. If there is sputum, and if the sputum is purulent, again. If the temperature is too high or too low, they're both bad, meaning fever or hypothermia, and you want to look at the culture results, and not just the results, but the sensitivities to antibiotics, so that you can tailor your antibiotics. We usually look at all of these components, but we don't do formal calculations. There is a way to do a formal calculation called the Clinical Pulmonary Infection Score. And this score was developed for ventilator-associated pneumonias, but people have been using it to assess general pneumonia response to treatment as well. It can be used, and comparing day 1 to day 3, the difference will give you an impression if the person is responding to your empiric choice of treatment without knowing what the bug is, or if the patient is not responding. Once you know the culture results and response to antibiotics, then you can decide if if the treatment is appropriate or not, but two-thirds of the time you're not going to get a particular bacteria and sensitivity, so you're going to have to depend on assessing your response to treatment.